Good evening. Today we'll be discussing about few of the current concepts in multiple sclerosis. We should be dealing with what are some points about prevalence, risk factors, and diagnosis. What is new in this? We'll be discussing briefly about radiological isolated syndrome. We'll have some update on current treatments. We'll talk briefly about progressive multiple sclerosis and COVID-19 on the pandemic time. So look at the prevalence, risk factors, and diagnosis. What causes multiple sclerosis is a genetic predisposition in the presence of environmental triggers. The autoimmunity is raked up, and there is loss of myelin and nerve fiber. That leads to multiple sclerosis. The prevalence worldwide, as this is shown here, and in India, it is about 25 per 1 lakh people, and that's a low density country. The high density countries are US, and which is 200 plus. US, UK, they are about 100, 200 per 1 lakh patients. So it's thought that in India it's never present, but we know that we keep seeing these cases now and then, and mostly we have to differentiate them from various mimics or atypical situations. The average age of onset is about 27 years. It's more common in women, and it's almost 2 to 3 times higher risk is seen in women. And recent studies cite higher incidence African Americans, lower in Asians. There's a wide range of onset, and there are some areas where the younger range is seen. Most common and disabling neurocondition in the young is this multiple sclerosis. The risk factors in the risk factors are mostly genetic and sun exposure and vitamin D. Now, the current flavor is about EBV virus, which we'll deal a bit. Obesity, especially in children, smoking. And the risk is decreased in pregnancy and after consumption of alcohol and caffeine. So the most important recent concept that has come up is that Epstein-Barr virus and multiple sclerosis. It's studied in a cohort of 10 million military recruits, and there are 5.3% were EBV negative in that, and they developed multiple sclerosis in the 801 MS cases in the cohort, and 1,566 controls. The 35 were EBV negative at the study entry. You can see that 97% of MS patients versus 57% of controls converted to EBV positive under observation. Now, the hazard ratio will be of 32.54. So no correlation to CMV, conversion, or other viruses. The NFL levels and filament levels, neural filament levels increase only after EBV conversion. So others think risk for the confounder effect is low. So these findings are accepted at present and was published in Science in almost 2000, a couple of months back. So what it says is extremely low multiple sclerosis risk in EBV persons suggests that most MS cases are caused by Epstein-Barr virus. And the important thing is that it could potentially be prevented by a suitable vaccine. So the EBV infection, the mechanisms, how can we say that? It's again molecular mimicry. And lifelong infected B cells, the memory cells are there in the body. The molecular mimicry and gives rise to autoimmunity. This the well-known mechanism for all the postgraduates. The B cell transformation takes place, and the CNS tropism is there. So these viruses are very, very important, and Epstein-Barr virus especially is very important. It's a very large study and published in this year only in Science, and you can see a 10 million military recruits. It's a good news that if we can develop a vaccine for the Epstein-Barr virus, we can prevent multiple sclerosis. About the genetics, the twins study revealed non-heritable immune perturbations in multiple sclerosis. 1:20 is the incidence in these twins, that is monozygotic twins, and there are also some polymorphisms and liver kinase B1. The risk for multiple sclerosis in whites and black Americans because of this particular thing is seen. And there are many gene environment interactions, especially vitamin D and sunlight. There are other important factors. So the most important that has come up lately is in published in 2022 on neurology, the association between time spent outdoors and the risk of multiple sclerosis. Children who are not spending time outside, then they are likely to develop multiple sclerosis. As you know, the age group is about 26 to 25 years, and if we are not spending much time outside, this is the latest research article that's published in neurology. So we all know that another important thing is the obesity. Obesity in children is a harbinger of MS in late adulthood. Okay. So types of MS. There is a radiological isolated syndrome, RIS. Suppose a person has some headache and you do an MRI and you see that there are some white matter hyperintensities which are typical, and I'll show you the diagnostic criteria. And there is second one is clinical relapse, that is clinically isolated syndrome, and relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis, RRMS, and then evidence for progressive disease. And another phenotype is a primary progressive MS, progression right from the onset, and if it is more than 6 months, then called primary progressive multiple sclerosis. Initially, it is only radiological isolated syndrome. There are no symptoms. Insidiously, the symptomatology develops. So diagnostic criteria are based on 5 important issues. One is identification of a syndrome typical of multiple sclerosis related demyelination. That means white matter disease. White matter disease means the optic tracts, the corticospinal tracts, these cerebellar connections to the cortex and the dorsal columns. These are the white matter tracts. Which there should be objective evidence of central nervous system involvement, not the peripheral nervous system. There should be dissemination in space and dissemination in time. There should be no better explanation. Schumacher in 1965 defined or brought out the diagnostic criteria when there is no MRI. So it is very categorical that each episode should last for about 24 hours, and the 2 episodes should be spaced by about 30 days. And it's a pure white matter disease. There should be no better explanation for that, and different neuroaxis to be involved. These are the things which he proposed, and they still hold good. Subsequently, we had Poser criteria, which are not reflected here, where we took the laboratory help, that is the visual evoked responses, brainstem auditory evoked responses, somatosensory evoked responses, and MRI and CSF all put together. The criteria is to be very cumbersome. Then the McDonald criteria have come in 2001. They were revised in 2005 after the discovery of aquaporin 4 antibodies. Again, revision took place in 2010. Now again, revision 2017 are aimed to facilitate early diagnostic possibility. And with the help of now, we can differentiate better because we've got commercially available of MOG antibody. So the McDonald, these criteria are named after Ian McDonald in 1933 to 2006, who was a New Zealand neurologist, who devised the original criteria with his international colleagues in 2001. These were originally introduced in 2001, revised successively in 2005, 2010, 2016, and most recently 2017. Let's see the dissemination in space on either baseline or follow-up MRI. Dissemination in time, these are two important aspects. And as you can see, any two should be present in the present McDonald criteria. That is more than one lesion in each of the two characteristic locations. Those locations are periventricular, juxtacortical, and posterior infratentorial spinal cord, and posterior spinal cord and periventricular. So all lesions included in dissemination in space and dissemination in time calculation. The simultaneous presence of any GAD-enhanced lesion and non-enhancing lesion at any time says it is dissemination in time, or a new development of any lesion, or a CSF which has got relevance now. Now, CSF was originally not there in 2007 and 2010 criteria, and that has made the diagnosis a bit difficult. Now, CSF oligoclonal bands are suggestive of dissemination in time. You can see now there are some pitfalls in the diagnostic criteria, which I'll tell. You can see in the left-hand column, all are clinical attacks. More than 2 clinical attacks, you don't require anything. More than 2 clinical attacks, one as well as clear-cut historical evidence of a prior attack involving a lesion in another anatomical location. That's as said by Shoemaker. That is another criteria. One, if it is one clinical attack is there, you have to demonstrate dissemination in space by an additional clinical attack history or MRI evidence localizing to another anatomical location. One clinical attack and more than 2, you've got number of lesions with objective clinical evidence, dissemination in time can be demonstrated by another additional attack or CSF specific oligoclonal bands if they are present. Number of lesions with objective clinical evidence is only 1, clinical attack is 1. Then also you have to dissemination in time by MRI or CSF, and dissemination in space by MRI. So these are the important additional data that is required for diagnosis of MS. So clinical syndromes that are typical of our optic neuritis, brainstem syndromes such as internuclear ophthalmoplegia, trigeminal neuralgia, and there are cerebellar syndromes, transverse myelitis. These are very typical. The diagnosis, the key point here is the diagnosis of RRMS requires confirmation of objective evidence of a syndrome typical for MS. At least one CNS lesion corresponds to demyelination on MRI for typical syndromes. I'll show you some differential diagnosis MRIs. The pitfall will be that without objective evidence, the McDonald criteria have decreased specificity. So objective, so mostly they are clinical attacks. The dissemination in space and time, let us see first step. Confirmation of objective evidence for a single attack typical for MS-related demyelination. So detection of lesions in more than one distinct anatomical location within the CNS suggests the dissemination in space. So MRI, 4 regions are defined: periventricular, cortical, juxtacortical, infratentorial, spinal cord. Dissemination time, evidence of ongoing disease over time. Changes and follow-up MRI maybe one of the reasons. Any GAD enhancing lesion and non-enhancing lesion on one scan will tell that this is dissemination in time. Oligoclonal bands, more than 2 are present, they can substitute for clinical or MRI data. So if only one thing is clinical isolated syndrome, and if there are more than one, it is multiple sclerosis. The role of MRI in the diagnosis of MS is very important. And 2016 MAGNIMS and 2016 Consortium of MS centers, they proposed standardized MRI protocols. The key point in this is MRI supports the diagnosis of MS, and atypical radiographic features should argue against this diagnosis, and which you are going to discuss. So what is it? That's dissemination in space of at least 2 of the 5 areas of the central nervous system. What are these 5 areas? More than 3 lesions should be periventricular, more than 1 infratentorial, more than 1 spinal cord, more than 1 optic nerve, more than 1 cortical and juxtacortical lesions. So at least 2 of these areas to be involved, and each area is again quantified. If it is periventricular, more than 3. So dissemination in space, you can see the spinal cord hyperintensity here. It will be short segment, less than 2 vertebral bodies length, and you can see the corpus callosum, the Dawson's fingers, the infratentorial images. You can see the optic nerve here. I see the juxtacortical here. These are the very, very important cortical juxtacortical locations, optic nerve lesions. The periventricular lesions, you can see them here. And juxtacortical lesion is this shown very much here. And the posterior fossa lesion is seen here. So these are the characteristic MRI findings of multiple sclerosis. You can see the spinal cord lesion. One of the important MRI criteria. So what is the role of CSF in MS diagnosis? While this was de-emphasized in some iterations of McDonald criteria, this has come back in 2017. Very important. It's an independent predictor of a second clinical attack. Using positive CSF as a substitute for a second clinical attack has allowed for earlier diagnosis and earlier treatment. And so this is best for outcomes if we start the treatment very early. So now the important things which Shoemaker said is there should be no better explanation. Then only you can diagnose MS. So as you can see, there's no gold standard for diagnosis of MS. There's a criteria. You have to put together all the criteria, then come to a conclusion. So there is a very, very careful consideration of differential diagnosis, and also careful attention to all the red flags. A better explanation for typical syndromes versus atypical syndromes, and includes inflammatory and non-inflammatory syndromes, which we're going to see in next couple of slides. What are the common inflammatory mimics? That is NMOSD, neuromyelitis optica spectrum disorders, myelin oligodendrocyte glycoprotein antibody disease or MOGAD, neurosarcoidosis, CNS manifestations of some systemic rheumatological and oncological disease that present with optic neuritis or transverse myelitis. So metabolic deficiencies, B12 deficiency, Lyme, syphilis, HIV, HTLV1 infections, and vasculitis, CADASIL, spinal cord tumors, and Leber's and leukodystrophies, and NMOSD, MOGAD, lupus, Sjogren, sarcoidosis, antiphospholipid syndrome, and cervical spondylosis. So there are so many of them, which one has to be very careful in in diagnosing MS, because the differential diagnosis is very vast. So let us see some of the important aspects. And if there is a severe or bilateral optic neuritis, mostly it is NMOSD or MOGAD. If there is a longitudinally extensive transverse myelitis, it is differential diagnosis is many. MOGAD, neurosarcoidosis, systemic rheumatological disorders, paraneoplastic or other rare autoimmune myelopathies, and gliofibril associated protein, CRMP5. These are all the other things which we have to think if there is a longitudinal extensive transverse myelitis. If there is any history of intractable vomiting, that is area posthumous syndrome, NMOSD. There is a myelitis with gray matter involvement, that is MOGAD. Cranial neuropathies are more commonly seen in neurosarcoidosis. Transverse myelitis or optic neuritis with high pleocytosis. Other infectious inflammatory causes will come into play, like NMOSD, neurosarcoidosis. If there are systemic symptoms of joint pain, skin changes, rashes, weight loss, then systemic neurological or inflammatory diseases are to be thought of. This is the differential diagnosis of MS. And the common non-inflammatory mimics include optic neuropathies and microvascular disease and neoplastic and functional. So we'll focus on clinical syndromes of myelopathies and optic neuropathies. So CNS inflammatory diseases as listed here, multiple sclerosis, which got a short peripheral T2 lesions in the dorsal and lateral columns. Aquaporin 4 antibody positive neuromyelitis optic spectrum disorder, which we call NMOSD. The longitudinally extensive T2 lesions, more than 3 vertebral bodies. Central cord, gray matter is involved. MOG, antibody associated disorder, long or short T2 lesions, non-enhancing. Conus involvement is seen, gray matter involvement, and a H sign. That's the gray matter is involved in both the dorsal and ventral columns and the central area. Acute disseminated encephalomyelitis, coexisting deep gray brain lesions. Neurosarcoids, the mild deficit of proportion to MRI findings, linear dorsal subpale enhancement, a trident sign, which I'm going to show you in the next couple of slides. Connective tissue diseases associated with Behçet's, lupus, Sjogren's syndrome, the long or short T2 lesions, systemic features of connective tissue diseases. Paraneoplastic, there are tract-specific lesions, known cancer will be present or risk factors. Glial fibrillary acidic protein, GFAP associated astrocytopathy, often with brain involvement as well as with accompanying features of meningoencephalitis. So these are the very broad diagnostic differential diagnosis of this. Sorry. Yeah. So now let's look at this multiple sclerosis lesions, which are short peripheral T2 lesions, which you can see here. The arrow is depicting it in the dorsal and lateral columns. And whereas aquaporin 4 antibody positive NMOSD, longitudinally extensive T2 lesions, central cord involvement. You can see the central cord, the white arrow is showing that. And myelin or the MOG disease are long or short T2 lesions, and they are non-enhancing lesions, and conus involvement is seen, and H sign. You can see the H here in this white gray matter, central gray matter. So the spinal cord surrounding area is the white matter, the central area is the gray matter. In neurosarcoidosis, milder deficit out of proportion to MRI findings, linear dorsal subpale enhancement, which this is what is called trident sign. This is a characteristic of neurosarcoid. There are some non-inflammatory myelopathies, vascular, spinal cord infarct, fibrocartilaginous embolisms, hematomas. These are all acute onset, except for AV fistula, which tends to be more subacute. Bleeding disorders, Valsalva with onset, etc. So they are the trauma structurals There are spinal cord contusions and neoplastic spinal gliomas can mimic them. Enhancement more than 3 months. Toxic metabolic needs, B12, copper, vitamin E, toxic like intrathecal methotrexate, and which is given in leukemias, vitamin B6, heroin, nitric oxide. The autoimmune and inflammatory optic neuropathy, we said two syndrome will identify. One is the myelopathy, the other one is optic neuropathies. Corticosteroid responsive optic neuropathies are sarcoidosis, chronic relapsing inflammatory optic neuropathy, CREON. Behçet's disease, SLE, also can cause optic neuropathies. Severe visual loss may be progressive. They're part of a multi-system disorder, and some ethnic clues are there: sarcoid in African, Afro-Caribbeans, and relapse with steroid discontinuation. Autoimmune causes for NMOSD, MOGAD, bilateral severe visual loss and presence of antibody. Para and post-infectious, the infectious neuroretinitis and acute disseminated encephalomyelitis. The progressive severe edema, systemic findings of infection, these are all seen in infectious causes, and they are bilateral and simultaneous and more common in childhood. Non-inflammatory optic neuropathies are ischemic, anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, diabetic papillopathy. Usually older age groups, sudden onset, painless, and there may be a field defect, which often is altitudinal. Toxic and nutritional causes and by B12 and copper deficiency. Bilateral and symmetric painless. That's bilateral painless visual loss, and with a family that is positive. Sometimes gliomas and optic nerve gliomas, aneurysms, they can press on the optic nerve and progressive painless visual loss. Foster Kennedy-Stryper syndrome is developed. So there can be misdiagnosis or alternate diagnosis when we encounter these patients. And 22% are associated with migraine, 15% fibromyalgias, 12% non-specific, non-localizing neurological symptoms with abnormal MRI, conversion of psychogenic 11%, 6% are neuromyelitis optica spectrum disorders. This is a 2016 neurology paper. So the different lesions, resolutions you can see. The MS is got a lighter shade, you can see, when compared to the NMO. And the location also, in NMO, it is aquaporine around the aqueductal location surrounding the aqueduct and area posthumous syndrome. MOGAD can have big lesions, and in both subcortical, juxtacortical, as well as deep gray matter can be involved. Large areas and cerebellum can be involved. And these are the differences in lesion resolution. You can see NMO spinal cord, a long segment myelitis, which you can see so long. And you can see that the central gray matter is also involved. And MOGAD is much bigger hyperintensities. And you can see they can be short also. They can be, the MS is short. And here, and MOGAD also can be short at times. The central vein sign, that's one of the important things that has cropped up. You can see a lighter thing in the opacity, the white matter hyperintensity. You can demonstrate a central dot. This is central vein sign with high prevalence of central vein sign in white matter lesions on susceptibility weighted images. And that's very important. You should look at in susceptibility weighted images where this white arrow is showing is the central vein sign. You can see a lot of these central vein signs have been studied, and multiple sclerosis they are present, but not in SLE and T phospholipid syndromes. These places they are absent. One of the important things is inflammatory vasculopathies. The central vein sign assessment is very low. In MS, you can see almost 100% stitching. So SLE, Sjogren, Behçet's, but MS has got a very high prevalence of these, and the distribution of brain lesion frequency also is different for MS and inflammatory diseases. See you can see the juxtacortical and leukocortical lesions are more common in MS. Subcortical deep white matter lesions are more common in inflammatory. Periventricular lesions are more common in MS. You can see how much are periventricular lesions, and infratentorial lesions are also more common in MS. So there is a distribution of these brain lesions also in these cases. So now we'll talk a bit about radiological isolated syndrome, proposed diagnostic criteria. The presence of incidentally identified CNS white matter anomalies meeting the following MRI criteria, that is ovoid, well circumscribed, homogeneous foci with or without involvement of the corpus callosum. These should be more than 3 mm, and Barkov criteria, at least 3 out of 4 for dissemination in space. CNS white matter anomalies not consistent with a vascular pattern. And this I'll show you in the next slide. The clinical, there is no historical accounts of remitting clinical symptoms. MRI anomalies do not account for clinically apparent impairments. They are not due to the direct physiological effects of substances. MRI exclusion of phenotype suggestive leukoariosis or extensive white matter pathology lacking involvement of the corpus callosum. These are clinical MRI anomalies not better accounted for by any other disease process. So this is, as I said, if you do an MRI for a migraine patient, you may come across some white matter hyperintensities, and we have to, these are the proposed diagnostic criteria. The question comes is whether radiological isolated syndrome can lead to MS. As I have shown earlier, you can go to progressive, primary progressive MS, and there is also brain atrophies associated with the syndrome, especially in thalamic area. The 10-year cohort found a 51% risk for conversion to multiple sclerosis. And out of this, 88% are RRMS, 12% become primary progressive MS. And what are the risk factors? They're all independent predictors of age, CSF, oligoclonal bands, infratentorial or spinal cord lesions. They all are suggestive that they may progress to the either RRMS or PPMS. GAD enhanced lesion on the initial scan, and the reason for scan not are predictive of what is the progress subsequently, but the above things are predictive. So in one of the largest prospective studies, 372 patients, a 2-year follow-up, high risk for clinical event include the spinal cord or infratentorial lesions, GAD lesions, age less than 37 years. CSF is not predictive, maybe because of study design in this cohort. There are only some people have undergone CSF examination. That's not a very reliable point. Is there any relation of cognition? Yes, patients with radiological isolated syndrome have been shown to have similar prevalence of cognitive dysfunction versus patients with CIS. Cognitive dysfunction does not necessarily correlate to the risk of clinical event, but it goes on slowly. You can see the normal volume of the subjects of radiological isolated syndrome and controls and the p-value. The thalamus is showing more atrophy. Left thalamic and right thalamic with a significant p-value. This is the controls, and and this is the radiological isolated syndrome. And you can see right thalamus and left thalamus. Their atrophy signals is likely fallout of RIS. Management, the best management of RIS patient is careful history and examination, complete imaging of the CNS, including the spinal cord, consider a LP, rule out other causes, follow-up imaging at 6 months, and then every 12 months. Currently, there is no evidence for DMTs, disease-modifying therapies. 3 trials are in progress with dimethyl fumarate, a RISE trial, actually I'll show you later, and teriflunomide, TERRIS trial, and ocrelizumab, CELLO trial. These are all in progress. Now, the part 3, the current treatment strategies for multiple sclerosis, and we'll see a group of how the drugs are grouped and classified. And you can see the subcutaneous intramuscular injection therapy, which we started giving somewhere in 99 as a neurologist. Then IV infusion therapies came. Then we were waiting, and suddenly oral therapies also came. And this is what we have seen as the last 2.5 decades in MS treatments. You can see interferon beta seron, but what I used initially was Rebif, interferon beta 1A in the 2099, and then beta seron came, then Avonex came, then Copaxone, glatiramer acetate, and mitoxantrone was already available. Now, after second line, this kind of Natalizumab, Tysabri changed the treatments, and then you have the PEG interferons have come, Fingolimod, that is Gilenya, teriflunomide. But in India market, dimethyl fumarate has entered very early. Twice a week regimes and Pegidry has come. Alemtuzumab, Lemtrada, and Ocrelizumab has come, and then subsequently we have Siponimod, which is very good for secondary progressive, Cladribine, and Ozanimod, Wofatumumab. This is one which is now in favor. So these are the developments between 93 to 2021. These many drugs have been, have come into the market. Look at the selective immunomodulation is given by dimethyl fumarate, which is an oral drug, and twice a day. Efficacy wise, safety wise, tolerability, all very well established, and we started using since 2013. And non-selective immunomodulation is given by interferons, IM subcutaneous and pegylated, also teriflunomide. That's the only one in oral therapy. Then the migration blockers and adhesion molecule inhibitors, Natalizumab, which are infusions every 4 weeks. We have large experience with Natalizumab, which we started using since 2008, 12, or 11, though it has come in 2006. We started using about 2012. The migration blockers, the Fingolimod and Siponimod, they are oral therapies and once a day, and they started in European countries 2010 onwards. And immune cell lymphocyte depletions, that is Alemtuzumab, Cladribine, Ocrelizumab, Metoxantrone. These are all subsequently they entered. So these are all the drugs of multiple sclerosis. And descending order of efficacy, the most efficacious, if you have to say, is Alemtuzumab, which is infusion, yearly cycle, and 4+ efficacy, safety slightly less, tolerability okay, and it is approved in 2014. And second is Ocrelizumab, which is also every 6 months infusion, efficacious and slightly better safety and tolerability. Natalizumab, which we have every 4 weeks infusion, and there's one problem of JCV positive, that is PML problems. Well, one interesting thing about infusions of Natalizumab has come up of late. That is nowadays they are favoring 6 weekly infusions instead of 4 weeks, and it's supposed to have reduced the JC virus infections. And mitoxantrone, Cladribine, oral and yearly cycle you can give. It's also effective, but not as effective as Natalizumab. Fingolimod also 3+, and dimethyl fumarate 2+, teriflunomide 1+, interferons 1+, glutamate. So the efficacy goes down, but the safety increases as you reach glatiramer acetate, and the tolerability is also better with Fingolimod and dimethyl fumarate because they are oral drugs, and most of them they don't like injections. These are the oral medications: dimethyl fumarate, teriflunomide, Fingolimod, Siponimod, and Cladribine. They are orals, and the Cladribine has got yearly cycles, and you can see they are much favored than the injections. So what I was saying is there's a PML risk for Natalizumab. The annual seroconversion rate is estimated about 2 to 3% per year. We should retest for the antibody every 6 months in seronegative patients on Natalizumab therapy. So we have to previously immunosuppressed individual is more likely to get. Length of treatment is one of the things. Titers is one of the things, and antibody status. All these will determine. So the antibody status and risk for PML can be calculated. If it is negative, less than 1 per 1,000. If the antibody is positive, then you see Natalizumab exposure. Is it 2 years? Is it 4 years? Is it more than 4 years? And then the index of suspicion comes. And the 8.5 is the things which you can have if the long exposure. And if there is a prior immunosuppression use, then in 2 years time maximum you can give 13 per 1000. So prior immunosuppression increases the risk of JC virus antibody, PML. So that's a very important aspect to calculate when we are dealing with natalizumab. So now what is this extended interval dosing with natalizumab? What they found was that if you extend the dose, the interval dose to 6 weeks, the less chances of acquiring PML in these patients. No evidence of loss of efficacy by doing this, but the advantage is that there is no. And the lymphopenia is always associated with most of these drugs because they attack the T cells and B cells. Some are B cell oriented, some are T cells. You can see cell lysis and depletion, alemtuzumab, CD52 receptors, T cells and B cells. Declizumab, CD25 and T cell depletion. Dimethyl fumarate, also NRF2 pathways and cell apoptosis. Fingolimod, this is T cells and B cells, and it prevents aggression into the bloodstream and retention in the lymph nodes. Natalizumab, it is integrin related VLA4 receptors and affect T cells, and crossing of the blood-brain barrier is stopped here. Ocrelizumab, B cells, these are the B cell therapies, CD20, cell lysis and depletion, and teriflunomide, and reduced proliferation of activated lymphocytes. So if there are less than 0.6 to 0.8 in 10 to the power of 9 liter per liter lymphopenia, then stop dimethyl fumarate and restart once the count increases. So when you stop fingolimod, we have to be careful about rebound phenomena, because it's all the lymphocytes that have been stopped suddenly start entering the brain and causes a lot of white matter damage. That thing will be kept in mind. Safety of ocrelizumab, the latest, has been established now up to 7 years of follow-up, and 400 patients, 11,400 patient years. There's no new safety concerns reported, like infections, malignancy, immunogenicity. So it's a very good drug for relapsing and primary progressive MS. Ocrelizumab, the flavor of the day is ocrelizumab. Whoever say that, the ocrelizumab is preferred, which is a CD20B cell related. So this has got a disadvantage in COVID infection. So if you look at these drugs, the mechanism of action of fingolimod is a non-selective S1P receptor modulator. Natalizumab inhibits leukocyte trafficking across the blood-brain barrier. Anti-LINGO-1 prevents a LINGO-1 from suppressing myelination. Ocrelizumab depletes CD20 B cells. Biotin, cofactor for decarboxylase enzymes involved in myelin synthesis. Siponimod, selective S1P1 and 5 receptor modulator. Lecanemab modulates cytokines, and simvastatin has anti-inflammatory, and this is now being tried in cases of simvastatin therapy in cases of primary progressive MS, the ongoing studies. So the target is no evidence of disease activity, what we call NEDA, the concept of disease-free state. In relation to 4 of these parameters, there should be no relapses, there should be no MRI changes of the treatment, and disability should be prevented. And if there is a brain atrophy, that acceleration of atrophy should be stopped. So if a drug meets all these 4 criteria, then we call it as a NEDA, no evidence of disease activity. And you have the data sets using natalizumab, fingolimod, and injection therapies. You can see natalizumab is the relapses wise, the disability worsening wise, radiological activity wise, it tops of all the 3 comparisons here, and that achievability of NEDA is maximum with natalizumab. Is an enhancing lesion on MRI correlates to clinical relapse? Enhancing lesion means there is a destruction of a blood-brain barrier, and meta-analysis of about 23 placebo-controlled trials showed strong correlation between magnitude of the effect of active treatment on MRI activity and on clinical relapse. So once you start treating, the gadolinium-enhanced lesions will go down. So there is a modified Rio score, which is an approach for determining responders and non-responders. And you can have the scores as per the after 1 year of treatment, how many T2 lesions have come, how many relapses have come. Based on that, you got a modified Rio score of 0, 1, 2, 3. And if the lesions are less than 4, it is 0 with no relapses. If there is less than 4 and 1 relapse, then it is score 1. If more than 4 lesions, it is also 1. If more than 4 and 1 relapse, that will be 2. So like that, the Rio score, modified Rio score after 1 year of treatment was able to predict the probability of disability progression at 4 years in RRMS patients with almost 70% accuracy. You can see the score 1, score 0, score 3, and the progression of for disability. This is the Rio score for you. The search for best treatment options, the treat MS, deliver MS, and when to stop. And when you, is it induction treatment or escalation therapy? Most often you are asked the question, Doctor, when are we going to stop the medicines? And so far, the answer is no, but we're awaiting the results of DISCOM, which is finished in May, which is another important trial. And dimethyl fumarate with placebo in RIS, that is the study which I was telling earlier. Oh, sorry. Which I was telling you earlier, that is ARISE study, and it's a multi-center randomized double-blind trial of the Tecfidra versus placebo in patients with radiologically isolated syndrome. 10 participants, 1:1 randomization, 2-year duration. Primary outcome they want to see is the time to first demyelinating event on a RIS patient. Secondary MRI outcomes at 96 weeks, and it's that analysis complete. And stay tuned for the result. The other one is TERRIS trial, teriflunomide, and multi-center European trial, double-blind randomized trial, and is also in radiologically isolated syndrome. 200 participants, 1:1 randomization, 2-year duration. Primary outcome is time to first demyelinating event. Secondary MRI outcomes at 48 or 96 weeks, and it's also ongoing study. Ocrelizumab versus placebo also is being studied, and 3 courses of ocrelizumab given over the course of the study, weeks 0, 48, and 96. The primary outcome is the first new radiological or clinical event. The principal investigator of the study is not at recruiting, but design is appeared in the news. So the meta-analysis of the age-dependent efficacy of multiple sclerosis treatment, how long we are going to give, all the drug trials which are meta-analyzed, and the conclusion that is given is that the meta-analysis supports the notion that age is an essential modifier of a drug efficacy. After age 53, the model suggests that there is no predicted benefit to receive immunomodulatory DMTs for the average MS patients. So this is the deadline which they have seen. So this is the PICORI discontinued DMTs in MS, the DISCOM study which I was telling. The randomized controlled non-inferiority, 15 sites, 300 patients, all types of MS, 55 years plus. Patients are stable, they are for more than 5 years. There are no new true relapses, no new MRI lesions, may have slow progression, half stay on DMT, half go off DMT, and they were followed for 2 years. And relapses were measured, EDSS, MRI, and all patient-related outcomes are measured. And the results are to be out by May end. So far, not visible, but they'll come very slowly. Thanks a lot for crisp lecture, sir. Okay. Okay. Thank you so much. Progressive MS, and we will do about the progressive MS. See, our main problem is secondary progressive multiple sclerosis, and minimum progression of 1 for EDSS less than 5.5 or 0.5 for if EDSS is more than 6. So there is a minimum progression of 1 score or 1 step in EDSS. Minimum EDSS, if it is 4, minimum pyramidal functional score is 2. Confirmed progression more than 3 months, including confirmation with a leading functional score disability. So there are some clear-cut definitions for research purposes of this. And the progressive MS treatments are also very difficult. Ocrelizumab, immune modulator, can be used B cell therapy. Metoxantrone, which affects both T and B cells. Siponimod also affects both T cells and B cells. And you can see ibudilast, and this is a brain atrophy related. And ibudilast is another which is drug, and simvastatin, HMG CoA reductase inhibitor, lipoic acids, biotin. All these drugs are they are in trial stages for progressive MS, which is very problematic area for us. But what we can do is symptomatic management and wellness recommendations, which include diet, etc. You see weakness, muscle spasms, fatigue. With you may give amantadine, depression, cognitive dysfunctions. All address the various disabilities. In patients with the clinically significant long-term disability progression, there's no difference between those with relapses and those without during the first 6 years of the study, as shown in the EPIC longitudinal study from UCSF. Pyramidal and cerebellar function scores worsened in patients with long-term disability independently of relapse, suggesting what? Silent progression. Data suggests that process of worsening disability occurs earlier than recognized by the patients or physicians. So this is what the wonder drug ibudilast, which is being shown as a slow whole brain atrophy when the patients are on this drug is less, and it's got a significant p-value, which is seen in this graph. So simvastatin in SPMS, a phase 2 MS-STAT study showed that simvastatin can reduce the rate of brain atrophy in SPMS. Patients took simvastatin 80 milligrams for 2 years and a 43% lower rate of brain atrophy. Better scores on EDSS score and multiple sclerosis impact score is seen in simvastatin. Siponimod phase 3 expand trial also is dealt with the secondary progressive, and this is disentangling disability and relapses in secondary progressive multiple sclerosis has been studied. The principal stratum analysis estimated that Siponimod reduced the risk of 3 and 6 month confirmed disability progression by about 14 to 20% and 29 to 30% respectively. So new therapies on the horizon: mesenchymal stem cells, autologous hematopoietic stem cells, ibudilast, simvastatin, and tolebrutinib in PPMS and SPMS. So these are all the studies which are shown in the one frame for better remembrance. And so the wellness approach, the nutrition, diet studies in MS. There's so many low-fat diets, SWANG diet, McDonald Walls protocol, Mediterranean diet, intermittent fasting. All these are supposed to help in the quality of life, exercise, emotional support, cognitive support. So then lastly, we talk about the COVID pandemic and the risk of developing COVID-19 on MS DMTs is very less. You can see all of them. The fumarate is a reference thing, and you see all these except anti-CD20, that is ocrelizumab. That's what is our main area where we have problems. So MS itself is not a risk factor for COVID-19. Most DMTs are not associated with increased COVID-19 risk. People with MS who are older and have higher disability or progressive MS are at slightly higher risk for severe COVID-19. Patients treated with ocrelizumab are at higher risk for severe COVID-19 in some studies. Anti-CD20s, Elamituzumab, and SAP treatments may not have that much risk. So patients on anti-CD20s, Elamituzumab, may not have adequate antibody formation after vaccination. So that's the recommendation is when these drugs are their vaccine doses at least 3 months after infusion, no closer than 4 weeks to the next. The primary series are 3 doses, booster 5 months after the 3rd dose. So vaccine has to be slightly adjusted in cladribine also till the WBC is reconstituted. So that's all from my side. Thank you very much for. So we have tried telling about some of the 5 aspects regarding the prevalence, the genetic studies, the EB virus, which is a hope that we can develop some vaccine about for the multiple sclerosis. And we discussed about the diagnostic criteria of McDonald criteria dissemination in time and dissemination in place, and also some aspects of the current treatment and primary progressive MS and COVID-19. And I think this new session has started for DNB and DM students. So now, hereafter, the neuro e-Pathshala classes will be regularly taken. We'll try and introduce neuroelectrophysiology once in a fortnight or so, which will cover EMG and EEG studies, and any other requests from any students will be taken up. Okay, then if there are any questions, somebody can ask. If there are no questions, then we'll stop here. I'll wait for a second, for a minute. Then if there's anything which you want to ask about the current concepts, which we can say. I think there are no questions. Then I'll take your leave. Good night.